this week on the BackTable podcast?
As a physician and also, our athletic trainers, we are the frontline healthcare providers for the teams that we take care of. So we have to take on the responsibility to check the wet bulb globe temperature before practice, right? So we need to know what to anticipate. Do we need to tell the coaches like, hey, it's a red flag today. It's like super hot. This may have to be like a no pads practice. So having a good communication with your coaching staff as well as the players and knowing the realities, like, hey, bottom line, we're here for the health and safety for all the players on the field at this very moment. Like, I'm not here to have anyone get a heat stroke.
Welcome, everyone, to BackTable Bone Sports podcast. Today, we have a great guest, one of my longtime friends, mentors, former faculty, Dr. Irvin Sulapas. My name is Larry Balle. I'm a primary care sports medicine physician who practices sports medicine, non-operative orthopedics, muscular medicine, and the Texas Medical Center. If this is your first time listening, download the BackTable app. Share, subscribe, tag, build playlist, send episodes, leave some comments. If there's something that you want to hear, let me know. You can also email me at larry@backtable.com if there's anything cool that you want to hear. I've had a couple episodes that have developed from some of those comments, and that's awesome that we're having some more input from our audience. Dr. Irvin Sulapas is, as I said, a previous faculty member of mine from when I was a resident. We've known each other for about 10 years or so, or probably a little bit longer.
Yeah. When did you start residency?
I guess
2014?
Yeah, so longer than 10
years.
years.
That was my first year as an attending, yeah.
That's awesome. And he was a sports medicine faculty that joined my residency over at Baylor College of Medicine. And from there, we worked together and we became friends afterwards. And kind of full circle, we were starting a fellowship at my current institution. And now I get to have the pleasure and opportunity to have Dr. Sulapas as one of the faculty members with me with the fellowship, which I think is amazing as well. Dr. Sulapas, give us a little bit about your background. Tell us a little bit about yourself and your sports medicine experience.
I've been practicing for about 12 years now. I did my family medicine residency and sports medicine fellowship over at Texas Tech in Lubbock. Shout out to all my folks in Lubbock there. My first job after training was being faculty for both family medicine and sports at Baylor College of Medicine, where my first year of being an attending, the first resident that emailed me was this intern named Larry Balle. It was like, hey, can you come out to help? Is there anything we can do? It's like, yeah, there's some like soccer, I guess, with like, at that time I was the team physician for Texas Southern University. And from there, the mentorship and the friendship kind of blossomed from there. And, during that time, Larry moved on, did awesome things with his fellowship and his career. During that time, I was the team physician for Texas Southern University and also with the Houston SaberCats with Major League Rugby. I was at Baylor for about 8-ish years. And then after that, I joined faculty over at UT Health Houston at McGovern Medical School. And I was there for 4 years. And during that time, I was the team physician for the Houston Dynamo, University of Houston, and also a couple of the high schools around Houston. So great time. And then there was a change in the winds of where like, hey, I think there was a great opportunity over at my current institution here at Houston Methodist. Dr. Balle was building something and decided to hop on and say, let's do it. I am officially here 6 weeks in the practice, and so far so good. Have to be here and sharing my expertise and knowledge for where I'm at right now.
Awesome. Yeah, thank you for being here. We have a very hot topic to talk about today: heat illness, wet bulb, globe temperature. Where we are in Houston, this is always a big thing. Even where I was with the University of Arkansas, we were still taking wet globe bulb temperatures all the time and making adjustments with practice. But it's very instrumental talking about outdoor sports down here. So let's dive in. Tell us a little bit about what is heat-related illness as far as a definition, or heat stress.
Heat stress is when it's not just sweating and feeling exhausted, it's a combination of things. So a combination of feeling dehydrated, feeling like your heart rate is increasing, sweating more, feeling more tired, it's more like you're feeling more tired than you should be. And it's usually because of that environmental issue. In terms of like the latter, I always think of something like there's a exposure, right? Being outdoors. It creates a stress, and you have that stress of a combination of environmental stress plus a metabolic stress and plus the clothing load, right? Depending on what you wear too. And that creates symptoms where you're getting a lot of like heat and having kind of disruption on your metabolic system, essentially.
Cool. Yeah. And, we're talking about clothing. Some guys, if you're just shirt and shimmel, right, is one thing, but you put on football pads in the fall, or really when fall camp starts here in 2 weeks, August, late July, that's a whole other level. Plus your helmet, those items or padding or whatever you're wearing then gets soaked in sweat. And then now you have a wet layer on top of you, and then you're sweating and you're in that 100+ degree heat plus humidity. We'll get into humidity as well. And that's something obviously close to the coastline that we're always talking about and, managing. So as far as heat related illness, why do you think that's such a big topic today?
I'll be honest with you, like it is feels more hotter than it was 10, 20 years ago, We're getting hot in humid seasons, depending on what the season is, I think this year we have a El Nino again. So like summer weather patterns change too. And sometimes with these kind of like weather phenomenons like El Nino, things are a little bit more humid than they were, right? Because of that, people are considering earlier preseasons, right? And that's even a topic even in the professional levels. Preseason is starting earlier. Sports specialization is a big thing now. I know that's a whole different topic, but like people are doing like year-round football or year-round soccer where they're going to be outdoors pretty much the entire year. There's been a lot of growth of that. Yes, there are still multi-sport athletes where you can do like a season of indoors, a season of outdoors, but when someone loves their sport, they're going to play it year-round, and it may be an outdoor sport. The linemen, I feel like, are just bigger than what they were 20 years ago too. So basically, it's just like multiple factors that can feel like you get a little bit more risk for any like heat-related illnesses.
Do you think we're seeing more now within the past 10 to 20 years than we did see before because of those factors? More heat related illness?
Not necessarily. I think it's probably more that we're being more aware of it, right? 20, 30 years ago, water was a punishment, right? Then now there's like mandatory water breaks. I think the science has evolved a little bit to where like we do these mandatory hydration breaks during practice and stuff because we do not want anyone to collapse in practice, right? So I think being more cognizant of the symptoms, I think we're just recognizing it more.
Yeah. I mean, look at the FIFA games, right? There were mandatory water breaks during the World Cup.
Right.
Yeah. It's where they're basically forcing the game to stop and then requiring that you at least break for a minute and then encouraging you to drink some water.
Yeah. And depending on where you are in the world with outdoor professional games, sometimes there is a mandatory hydration break depending on the temperature on the field.
Yeah, which I think is some of what we'll talk about here in a minute with wet bulb globe temperature. Okay, so talking about, you mentioned sweating, you mentioned some of the cooling process. What are some of the things that the body does normally, and what are some of the other things that we can do to help regulate temperature as far as our athletes?
Multiple things, right? So if you're thinking of the environmental factors, timing of practice is important too. Trying to avoid practice between like 10 a.m. and 4 p.m., depending on where you live in the part of the world. I feel like a lot of the high schools are starting to practice a lot earlier now. I'm sure you see it too, Larry, of 6 a.m. practices for these high school kids. It's no longer just reserved for the college athlete, and also the 7 p.m. practices too. And unfortunately, that's just where you are part of the world. So timing of when to practice. We briefly touched on clothing, right? Light fitting clothing. Since we're a little bit more season 2 football, there could be no pads practice to help. And then when it's cooler or like later on when the sun is down or something, then you can do some pads practice. So helmets versus no helmet kind of practice. Heat acclimatization is also a big thing too. You saw it in the preparation of these national teams preparing for the World Cup. They came into their base camp 2 weeks before they really need to do things so they can adjust to the heat, right? It does take about a week or two to acclimatize to the temperature environment that you're practicing in. So all these kind of add up in terms of factors to help kind of mitigate and decrease an incidence of a heat-related illness.
Cool. Yeah. Acclimatization is a big thing. Hopefully, the high schools in the area are doing it. Most colleges, I feel like, really influence that. And that can be a big factor. Is, most organizations have some kind of recommendation, whether that's like here in Texas, the UIL or SEC, as far as some of the collegiate stuff, Big 12, right? American Conference, they should have some recommendations. I know that's always talked about in our EAPs as well for the collegiate sports. What about as far as the diagnosis and the definitions? Give us a spectrum of heat illness. So all the way up to like a true heat stroke.
Yeah, the first thing you kind of want to do is like a minor stuff is I think the most minor thing you can have is a heat rash. Miliaria, that's where you kind of like occlude the ducts and it can sometimes impair sweating. So you get this like little heat edema. Sometimes people get it on their chest or on their back or on their neck. So I would say that was probably maybe the early minimal thing there. Outside of that scope, you can have a little bit of like a heat syncope episode, which does happen. That's more of an orthostatic postural kind of thing where you have this like cutaneous vasodilation with a loss of like muscle pumping. Typically, right, and you stop from the exertion, right? Like you're doing like gassers and then you're like, oh, I'm good. And then you don't keep walking and then you pass out. We see it all the time in the finish lines, in long distance races. Those two, you just keep them cool and their core temperature is all right, then they'll be okay. But if you get to the next level of that is, heat exhaustion, right? And that's the one where you have like the inability to continue your exercise or your sport. But the key difference is that your core rectal temp, I know we get there, is less than 40 degrees centigrade or like less than 104 degrees Fahrenheit. And then however your central nervous system is completely intact, right? You could converse with them and stuff like that. The big thing that we always worried about is the big emergency, which is that exertional heat stroke or heat-related heat stroke. And by definition, that is if your core temperature is 105 degrees or greater Fahrenheit, and you have central nervous system dysfunction. Both are required, okay? You have to have CNS dysfunction in order to diagnose that, because you can have a 105-degree fever and still talk. You technically do not have heat stroke. You still have heat exhaustion, but it's not a stroke. And I think that's going to be the big difference between the two.
Have you seen anything like that in your career? I'm sure.
Heat illnesses, heat exhaustion. Yes, I do serve as one of the medical captains for the Chevron Houston Marathon. So there's always like one or two guys a year that may get into like the heat stroke category to where we kind of go ahead and dunk them and then, send them to the hospital afterwards. One nice thing that we did starting the last couple of years with the marathon is that we implemented with every aid station every 2 miles is a TACO, TACO, which is a tarp assisted cooling oscillator. For those who don't know what that is, it's like instead of like a tub of cold ice, you just put them in a tarp and then you just dump ice on them and then you get a couple of guys to go side to side and then you just kind of like roll them out so they can kind of get that immediate immersion till you get like the sag wagon to come and pick them up. Because, immediate cool immersion is like going to be the mainstay when you're concerned for the heat stroke.
Yeah. Yeah. We started talking about that a lot when I was still at the University of Arkansas adapting from the tubs, because you're out there and, Arkansas is not as hot as Houston all the time up in Fayetteville, but you're out there in 90 plus degree weather on the turf. That ice tub is no longer an ice tub. And, towards the end of practice, it's more like a hot tub, right? And they're typically black. And with those methods, you can have fresh ice and fresh cooling surfaces compared to, some black tub that's been sitting out there for 4 hours of practice.
Yeah. The tarp's easy. You just roll it up and then just have it in there in case for emergencies. You just roll it out. Someone rent some ice and just dump it.
I remember when I was a resident and I was covering the marathon and I was in the major medical area of the George R. Brown Convention Center, and they brought a guy in and he was one of the first ones to finish the half marathon. And those are, all the experienced guys. I think it was my second year to be there, and all the experienced guys were like, you got to watch out for the first ones. It's a cool morning. The people that come in first are usually the ones that are going to have heat illness. And, tall, thin guy, heat exhaustion, brought him in. He's out of it, delirious. They dunk him. not coming to, but as soon as they stuck the rectal thermometer in, he jumped up and immediately came back to, and he was, swinging and fighting everybody. But they brought him from the ICU area over towards the major medical once he kind of came to. But they were yelling for all of us to come over there. He's in the tub, and they were trying to get a core temp on him, and it was high. But fortunately, he didn't have any end organ damage. That still sticks in my head from 8 years ago, 10 years ago.
Yeah, yeah. And I'm glad you mentioned that, because the real big reason why you have to watch for a stroke is that if you think of just like your regular stroke, you can have that risk of end organ damage, right? This is why you have to like admit them to the hospital. They might come out of that altered mental status and talk to you, but you're still at risk for organ damage, right? You still have to check their CMP. You have to check their coags, right? Because DIC can still be a risk, right? You got to check their rhabdo. They could have an acute kidney injury. I mean, when I was a resident, we saw somebody, and this was in Lubbock. This person was trying to do an ultra marathon, and he wanted to run 50 miles before he turns 50. Now, this wasn't heat related on us, but while he was running, he was hurting. Obviously, it's a long run, and he would just pop ibuprofen every like 5-10 miles, and he ended up having like NSAID induced nephropathy, whereas creatinine was like 9 and all those things. So, but even like related to heat illness, like hepatic injuries is going to be a risk, renal injuries. That's why we have to like admit them, monitor them, and make sure that we're not developing into some other organ issues.
Yeah. So, you're talking about getting labs, you're talking about keeping vitals on them. And then typically they're going to have some fluids running just for observation and rehydration, right? So most of that time, like if someone comes into that, like for example, that major medical section of the marathon, they're not leaving within 5 minutes. They're at least going to be tanked up with fluids, reassessed, and then, going to be there for an hour or so, at least, if not a few hours before they head out. Or if they're, getting shipped over to one of the hospitals. Let's go into a little bit more of the wet bulb globe temperature.
Yeah, so wet bulb globe temperature is a little different than your regular temperature. I was like, what the heck is this wet bulb globe temperature? So it's a combination. I don't want to go over through the formula because sometimes I have to look that up in terms of what the formula is. That's more of like a fellow thing, guys, in terms of for your boards. But it includes not just the temperature of the environment, but it's also like how it takes humidity into play. Yeah. And then also like the evaporative capacity of the environment that you're in. So that's where the wet bulb and also like the radiator. Remember, like heat has like a conductive force and a convectional force. There's this formula that kind of like creates that wet bulb globe temperature. So with dry air, radiant load, and also evaporation. It's a little different from a heat index because a heat index is based on temperature plus humidity, but it omits like solar radiation and wind from the heat index. A little bit of history, the wet bulb globe temperature, it was technically developed by the US military back in the 50s, specifically for exertion outdoors. And that's what we use to settle it. For those who have done any sort of exercise outdoors, temperature really doesn't matter. It depends on how humid it is too, right? That's why some people can like, if it's dry heat, 90 degrees, it feels a lot better than a really hot and humid 82 degrees. So wet bulb is really an instance of how bad it's going to be. I wanted to add that like when you do a wet bulb globe temperature, you have to do it in the playing surface, right? If it's turf or grass, about 3 to 4 feet above ground, and then you kind of reassess it in like 30-minute intervals.
Yeah. We had a whole setup for the football turf field at Arkansas, and they had one wet bulb globe temperature testing kit on the grass, and then they had one on the turf, and they would use a comparison. And so they'd actually determine which side they were practicing on that day based off of lower risk, or if they were both within a reasonable range of each other, they were able to practice on either. And there's one AT that was his job, was to do that every day and keep track of it throughout the practice. I didn't realize until that time, like what you said, that you're using multiple readings. You're not just using like, oh, yep, we're good to go for the entire practice, because that can fluctuate and change throughout the day based off of ambient temperature and ambient weather, right? If, cloud coverage comes over or light shower comes in, your humidity drastically changes. So there's more than one variable than,
Yeah.
just taking the temp.
I can tell you in Major League Soccer, prior to this World Cup where you saw those mandatory hydration breaks, the hydration break rule in Major League Soccer is that they'll check the wet bulb globe temperature about 30 minutes before kickoff. And if it's greater than 83 degrees Fahrenheit, you're mandated a hydration break at the 35th minute. The ref will recheck it right before the second half to see if they need to add one in the 75th minute. Because, sometimes like it cools off, in the evening, especially with a 7 or 7:30 p.m. kickoff. So they may not need that mandatory hydration break because the temperature went down. So even in like a professional soccer, they'll recheck that wet bulb globe temperature for the second half.
Yeah, that's cool. If you don't want to stop the game, right? Or if you don't need to stop the game, why would you stop the game? Yeah. What are some of the things that you would consider as far as sports? Like, where are we going to be using this, or where should you use this? You've talked about, and you have experience with professional rugby, you have experience with professional soccer, you have experience with collegiate sports across the board, high school sports across the board, mass event coverage. Do you think this is applicable to all outdoor sports, or is it seasonal, or is it more of specific sports in general or endurance sports? Is there something particular that you would look at for that?
Any outdoor activity, right? Because you're thinking of not just like player safety, just safety in general with the outdoors, You can even do it like occupational, if someone's out there doing, you know, oil pipeline work or construction, it's something to consider for like, hey, do we need to have like a mandatory like water break or a cooling break while you're out in the sun working in construction or other things that involve being outdoors, like landscaping or carrying things. So there's these, I feel like support for anything outdoor related.
Cool. As we're talking about that, I'm thinking, you know, some of the rhabdo that I've seen just as a physician, family medicine physician, is from construction workers, right? From guys that are working on houses that are outside in Texas, from people who are doing like road work, right? That are on the asphalt, and they're not necessarily doing anything too strenuous, but they're so dehydrated that now they're having that muscle damage. So, okay, that's a good point. I hadn't thought really about that as much. What about as far as your athletic trainers with the teams that you work with? Are there certain, so you mentioned 83 degrees. Are there certain things that you would tell your athletic trainers for the teams that you work at, or recommendations you would tell them?
Yeah, as a physician and also, our athletic trainers, we are the frontline healthcare providers for the teams that we take care of. So we have to take on the responsibility to check the wet bulb globe temperature before practice, right? So we need to know what to anticipate. Do we need to tell the coaches like, hey, it's a red flag today. It's like super hot. This may have to be like a no pads practice. So having a good communication with your coaching staff as well as the players and knowing the realities, like, hey, your bottom line, we're here for the health and safety for all the players on the field at this very moment. Like, I'm not here to have anyone get a heat stroke.
So you brought up coaching staff. I think that's a huge thing because they're the ones that are going to fight you back on a lot of this stuff. They're not really fully understanding. And I've had coaching staff, when we've talked about heat related illness, bring up their apps on their phone and talk about, oh, well, the temperature only says it's this. And I'm like, well, we're not taking into consideration all the other factors that you have already talked about, right? Is there an app that you're aware of that can accurately talk about these things? Or are we going more off the actual measurement with the wet bulb globe temperature assessment?
Ideally, you should have like a wet bulb globe temperature. You can buy one of those things. They are a little pricey, not 4-digit pricey, but maybe low 3-digit pricey. We only need one. So the way I'll talk with the coaches or into the staff is like, oh yeah, the temperature only says like 85. And then I'll go, look out there, look at that turf. You see those wavy lines coming up from the ground? Yeah. It's not taking that into consideration, right?
I went to a big football school in Houston, and we played at our home stadium. We would practice there during the playoffs, and then we would do our spring camp there. So we do a lot of practice. They'd bus us over. It was the old AstroTurf. And so you would get turf burn from falling and like sliding on the AstroTurf, but it would get so hot in the summer, you would get a sunburn if you're not getting drug or not, sliding just from the turf itself, because that turf would be 10 to 15 degrees hotter than just the ambient temperature.
Right. That thing absorbs and reflects, right? When people get sunburn from skiing and it's just the white reflection, right? The temperature on your app and with the weather does not indicate how hot it can really be. So conduction of the heat from the playing surface matters.
Yeah, the turf is a huge factor in that, right? Grass can play a role too, but the turf is going to, especially depending on what kind of turf, whether you have that carpet turf or, the more like the newer
The grainy
artificial
one.
grass. Yeah. What are some of the levels of risk that you would provide when you're giving a wet bulb globe temperature? So if you're talking about, okay, we're talking about youth sports versus high school sports, collegiate sports, professional, or even military, professional, like you mentioned, as far as like occupation, what are some of the risks that you would provide based off your temperature? Like, are we talking like, because we're looping in today, heat related illness as a spectrum, and then the wet bulb club temperature, which I feel like that thermometer gets forgotten often when we talk about these things. So if you're going to talk about the risk, are you at a higher risk when you're younger? Are you at a higher risk when you're older? Are you at a higher risk with obviously specific sports? Is there some kind of stratification that you would provide for your coaching staff and your athletic trainers?
Yeah, I'm glad you brought that. I like to call that maybe special populations to consider,
Okay. Yeah.
right?
Yeah.
I think the NATA, like the National Athletic Trainers Association, just came out with a position statement about heat month. The position statement specifically said the highest risk of heat-related illness in American sports is football linemen. And they have their own consensus statement because these are larger and stronger individuals, this being linemen. They have more body mass. They wear the equipment. The timing of their sport is like, as you said, like football practice is starting in essentially 2 weeks, but these kids have been practicing all summer in appropriate position conditioning, right? With all the pads and the dry fit. So I feel like football lineman is going to be a big consideration in terms of watching for heat illness. Endurance athletes, specifically if anyone covers or helps manage medically at long distance races, you worry about the ones in the finish line, that final surge to finish. They kind of like force it to where like they may be at risk with some sort of heat related things. Cause people sometimes they'll stop right at the finish line and then they're either heated or they'll like vasovagal, right? And then like pass out. The youth, they have a higher surface area to mass ratio. So for kids, like maybe kids under 12, you always have to watch children when they play outdoors. Children are physiologically more heat intolerant than adults. So make sure that they always have adequate water breaks, especially if you're having, if you have a little young one doing Saturday morning soccer and all those things. While we're in the realm of soccer, especially given the World Cup summer, soccer is one of the big things because it's one of that sport, that and rugby, which is continuous play with limited stoppage. That's why there's these like heat mandated cooling breaks depending on the football globe because it's a running clock. And then they'll add more minutes for any kind of injury. So baseball would be a long solar exposure, sometimes even standing, especially in the outfield and stuff. That can create some issues. Catchers in full gear, I would watch for, even though you think it's a low risk for being a catcher. But if anyone who's ever been a catcher with that full gear, like with a 12 o'clock noon game, it'll get to you. And of course, also like older adults and our athletes with disabilities, those older individuals, they may have a reduced sweat rate and decreased skin blood flow. So any of our older active individuals or weekend warriors, they may be on certain medications that you have to watch out for, especially if they're on a diuretic or some sort of like anticholinergic. Those are the kind of people I also try to watch out for.
Speaking of, what about amphetamine salts or ADHD medication?
Yeah, so any of those kind of like stimulants, may increase heart rate. Those individuals, if they are on those medicines, they just have to stay on top of their hydration.
Yeah, urinary output typically goes up with those as well, and your diuresis can predispose, just like what you're saying with diuretics. That's always something with the collegiate sports that when we have someone that has heat illness, there's so many people with diagnoses on ADD, ADHD that I start talking about, or when we were talking about like in collegiate sports, sickle cell trait and heat illness, that's a big topic. There was a whole thing at Rice, this was way before I got here, but with an athlete who passed away from sickle cell trait and heat-related exhaustion and stroke. But that's also screened upon, when you come in as a new athlete for most NCAA programs.
Yeah, and in the sports medicine world, we actually have I think we have an acronym for it, right? It's a ECAST, right? Like exercise collapse associated with sickle cell trait. And that's a ECAST, especially with someone with sickle cell trait in the collegiate athlete world, they may cramp more than the other person. For the athletic trainer and the physician, we should know who on the team actually has sickle cell trait. So they may need more hydration. We have to watch to make sure that they're not necessarily having that exertional rhabdo, but like, are they actually creating some sort of like early fulminant rhabdo, we have to worry about. So you kind of have to escalate a few things if they get really, really bad cramping.
Cool. Tell me about heat. Well, you touched on it, heat acclimatization. Give me an overview of that and like how you have that conversation with teams. You have a ton of experience with mass event, and professional sports that are outdoors.
Yeah. So with heat acclimatization, typically it takes around 7 to 14 days of progressive exposure, right? We saw it firsthand with a lot of European teams coming to America to train for the World Cup. And typically, the NCAA model has it to where like on the first 5 days, it's just a single practice day. Maybe like for football specifically, you can only do like helmets only, right? On like days 1 and 2, like no pads, helmets only. And then once you acclimatize to it, then you can add shoulder pads and maybe days 3 through 5. But you don't do full pad workouts before like either day 6 or day 7. Now, there's a whole different philosophy on 2-a-days now, but for those who do 2-a-days, you don't do any 2-a-days before even the first week of heat acclimatization, and you never do it on consecutive days, all right? You have to have some sort of like recovery day that follows a 2-a-day. Practice should be limited to less than 3 hours on 2-a-day days, and then you have to have an appropriate amount of like recovery in between. So you just increase it to where like the players get used to the heat, really. Now, things to consider in terms of risk factors while you do this, right? If someone had a previous history of exertional heat issues, they may need to take a little bit longer. Anyone who has like taking medications or supplements, you talked about stimulants, anyone who's on like anticholinergics or even like over-the-counter antihistamines, because antihistamines also impair sweating, anyone on diuretics, SSRIs. And that's why like in the preseason we gotta know, hey, what meds do you take, what supplements do you take, because this may or may not affect you for anything when but you always have to take that in consideration. Also, if they also have sickle cell trait.
Yeah, that's very all encompassing. Talk to me about the diagnosis. What are you looking for as a clinician? What are some of the symptoms that you might see? And what are you, when you do an exam, what are some of your findings?
Well, if they're talking to me, we're good. That's usually my first thing. If we're having a conversation, you tell me what's hurting, we're good. It's not heat stroke. So yeah, if you're able to converse with the athlete, you just kind of talk like how you do in the clinic. Tell me what's hurting. What are you feeling? What's cramping? Like what's bothering you? Do we need to get you cooler? Do we need to cut off, this shirt? Do you take the pad off? Do you need help taking off these pads? So have that conversation with them and then see what you can do to help mitigate it. They may complain of like dizziness, nausea. Oh, I feel like I'm out of breath. And it's like, and then okay, talk me through it. All right. And we'll lay down, we'll have you lay down, keep the legs up, maybe get some ice into like the bigger arteries and veins, like in the axillary, cooling, get a cold, washcloth on their head, and then just talk to me. Just talk to me, tell me what it is. And then, usually after you talk to them a couple minutes, they'll figure out what's going on. And they usually kind of calm down a little bit. What's the one that you worry about is when they're not talking to you, and that's the one. If they're like looking, it looks like they're looking through you and not at you, and they're not responding well. I'm like, all right, man, dunk them. It's the best we can do it.
That's where the cool first, transport after term
Yeah,
comes from, or
yeah.
the saying, right?
If something's fishy, yeah, you dunk them, and then you check their rectal temp, and then you kind of go from there. Call EMS, have it in your EAP.
Why is the rectal temp the gold standard?
So with the rectal temp, the reason why you can't trust non-rectal temps, I'll go with that. It's because you do have like the evaporation, the conduction for it. So it doesn't really assess like the true core temperature. You still have some exposure to other things if you're doing like an oral or a tympanic or like one of those like scan things that you get right, the infrared stuff. So it just adds more variables and it's not as accurate. So the rectal temp is really our gold standard because it takes away all this noise from outside things, and it's just more accurate that way.
I presented for our citywide athletic trainers a year ago and on emergency action plans. And I brought that up where I did my fellowship with University of Arkansas. There's a guy, Brendan McDermott. He's a PhD athletic trainer who has a lot of involvement with the Corey Stringer Institute. Corey Stringer was someone who passed away from heat-related illness. And the Institute's mission is to educate and to reduce the chances or likelihood of other people having heat-related illness. And so that was really instilled in me, rectal temperatures. And it's a hard conversation to have where, especially depending on the level, right? I think when you're collegiate, when you're professional, they know that you have the best interests in mind. And one of the questions I got was, how am I supposed to tell the, 16-year-old high school athlete's parents, like, we're doing this and this is necessary? And this is not a perfect answer. There is no perfect answer. If you were to have to explain that, how would you navigate that conversation?
I say, well, he's not talking to me. So if this is something wrong, he will. And if he's not, then that's how bad he is. And we didn't get to do it. So like you mentioned from your story, if they come in, arms shooting out, then hey, you just woke him up. Maybe he just need a little strong hand to talk. But like if you do, honestly, if you're concerned of like a heat stroke situation, if you're doing a core rectal temp, they won't even know. And if they don't know, that's worrisome.
Yeah. The way that I answered that question was, if I'm doing this, the way that I would say it is, you can always defer to me. And if I'm there with you, and if we're doing this on your child, this is to make sure that we are sending your child to the hospital or not. And, I was like, you leave it at that. And you know, when you typically go with an extreme in a situation because of the information that you're going to get, no one's going to argue with you. And that is the gold standard. If you're just doing rectal temps on everybody, that might be a problem. But I mean, from my experience at a big mass event where we had a ton of overheating at the Houston Marathon, maybe a handful of people had that done, and that was distance runners. I'm thinking back to when I was a fellow and even as a faculty member in Arkansas, in Eureka Springs, which is a very hot area in northern Arkansas. There's a event there, triathlon, called the Eurekan. It's just a sprint, but it's in late July. So it's a sprint try. But I mean, you have all kinds of heat. And I covered that for, I think, 5 years or 6 years. We never had to do a rectal temp on somebody. So that's the other thing, like, that I would tell people, if I'm doing this on you, it's in a reserve situation where it's necessary, and I think you either tell them like they're safe or they're not safe from that. And yeah, the outsider looking in who's never been in that situation would have a harder time having that conversation, where once you've done it and you have the reason to do it, it makes it easier. Not that you need to be doing rectal temperatures on everybody, but in that situation where you're worried,
Yeah.
it will give you more
Yeah.
information.
Let's just say in a marathon, I only carry rectal thermometers. So if you're saying you're high, man, like, yeah, that we only carry that in a mass event kind of thing.
In that case, now that we're talking about this, when would you activate EMS or in that situation, heat illness? We're going away from the wet bulb globe temperature. We're talking more about situational. At what point you mentioned they're not responding to you? Is it the rectal temperature? Is it the lack of communication? Is it some of the labs? Like the marathon, we had POC labs that we could get. What are the points where you're like, all right, we're going?
Right. And, not every place will have like a POC rapid CMP like right at your availability. So in the stadium EAPs or the practice EAPs, it's you dunk them and you call, right? Dunk them, activate the EAP, get EMS in here because we'll see how if this person gets better afterwards. But whenever you make the decision to dunk somebody and they have some sort of like CNS dysfunction is when you go ahead and call EMS.
Yeah, and for everybody that's listening that may be involved in sports and may not be as familiar with EAPs, we're talking about emergency action plans. Most of them have a policy that's set forth, whether it's a school, an institution, university, or if you're with a professional team. And typically, if you're the team physician, you should have some involvement in that EAP at least yearly for adjusting it or making different plans. And then likewise, if you're new to a team, that's typically one of the first things that they give you or that you review with the staff is your emergency action plan. And so that's what Dr. Sulapas is mentioning when he's saying activate it.
Yeah, and it encompasses, I know we're here specifically with like heat stuff, but it encompasses literally everything imaginable. Weather delays, lightning issues, the logistics for the ambulance to get onto the field, which way, what hand signal should you use in case you need to get an ambulance onto a field if it's a live game. And the EAP is different from each stadium. It's location dependent as well.
That was one of the first things I asked about with my high school that I just got in Houston. So it's good to have on hand and be familiar with. We're talking about cold water immersion if you're concerned or worried. And when I was a fellow, the things that were described to me is if you're hypoglycemic, dunk them and we'll check blood glucose. If you're, having some other kind of issue, dunk them and we'll figure it out after we go. But never hesitate to dunk if you think someone has heat-related illness. And typically you're trying to dunk in coldest water or coolest water possible. Do you have recommendations on that? Is it temp? Is it ice? Is it just some body of water? Is it anything? What are you telling your guys at the marathon with the taco?
Yeah, well, I mean, with the taco scenario at the marathon, you just get like a bag or two, and then you just kind of put them in, and then just kind of oscillating, right? I believe the gold standard for like a cold tub immersion is, I think the temperature has to be like 35 to 60 degrees, something like that. I think, yeah, it has to be cold to where they can get a good cooling rate to cool their temperature down. That's the fastest way. The second fastest way would be the taco method, the tarp assisted cooling oscillator. That one's actually acceptable, especially if you're in a scenario where there's no like access to a tub, but the rest don't work as well, like a cold shower or just put a couple ice packs on fans. So if you're really worried, you dunk them or you put them in a tarp and just throw ice on them.
Yeah. Yeah. I think the ice is probably anything cooler than your current temperature is going to be beneficial, but anything that's, ice or ice water is going to be, helpful, right? We talked about EAPs a little bit. Who all should be involved? And, I mentioned my experience with them. Who all should be involved, or what are your recommendations on EAPs as far as the committee, who should be reviewing it?
So a team of your athletic training staff, the physicians involved in care of the team, but it also should involve stadium ops, right? So anyone in stadium operations, they need to know where everything is as well. Depending on what your EAP is, sometimes it could be the groundskeeper guys, or let's just say in soccer, the people who do like the stretcher crew, right? Maybe not have them like an abbreviated version of their EAP, but this is, why you practice your game day scenarios or emergency procedures before the season starts.
I won't name specifics or specific teams, but I had experience where we had to remove somebody on a spine board from a stadium. And speaking of, that's a really great point that you just mentioned, ops, groundskeepers, security. The stadium was designed in a way that in order for us to get the person on the spine board out of the stadium, we had to take them from the field through the tunnel back towards the training room, go to the elevator that was adjacent that, had been done. They had remodeled that portion of the stadium. So the entire, end zone and area of it. So the year before. So this is our first year that we're playing there. We had to get on an elevator, go up the elevator to the ground level where like the street level is, come out of the elevator, go through the main concourse of the stadium, go to another elevator and go down to the bay where the ambulance was, and then take the person on the spine board all the way out. So the coordination that it took to spine board somebody was insane and that was the quickest, easiest way to get down there, to get to the closest ambulance in order to get them to where they were supposed to go. Disaster.
Yeah, that is disaster. Like the last thing you want is like a medical professional. Well, obviously the last thing you want is like a really bad outcome, but like when you're covering games where thousands of people are watching, everyone's watching you. And then you'll get the backseat section 400 dog, but like, they're not doing that right. How are they doing that? So like, this is why we practice and we set protocols. So when you're on the field and something drastic happens, it doesn't look like a bunch of 12 guys or girls just looking lost and like, what do we do next? Right. We practice and we hope and pray that we don't have to enact any of these scenarios.
Yeah. I remember being a resident with you guys at Texas Southern for one of the football games. And we spine boarded one of the visiting teams from Bacone College, I think is what, and the flow and to get the guy off the field, was I remember thinking like that was like 90 seconds to 2 minutes from the times that we got down on our knees and I was a resident, I was observing, and trying to help with straps and do whatever, but getting the whole flow of it felt forever, but the actual timing of it was super quickly. And I
Right.
think
And I'm sure you've spine boarded more since then, but you realize once you practice it, is you just go and take care of it.
yeah, that moment, where you remove all the emotion and you do what you're trained to do. It's a crazy experience to go through. Okay, next, let's go into some questions about, we talked about EAPs. We talked about some of the things that you can note with patients with screening and talk to them about physicals. Let's talk about return to play. What are your recommendations after someone's had a heat-related illness on getting back into sports?
Yeah, no, that's a big one, especially with someone who's had a heat stroke. You always want to make sure that they're not going to get back. So let's say after heat exhaustion, let's go with the minor thing, right? They're just a little bit overheated and they needed to like, step away from practice or whatever. With the heat exhaustion athletes, they can return, I would say probably a couple days once they're symptom free and they've physiologically recovered. And then you kind of slowly ramp them up in a graded fashion. But make sure that you ask this athlete, is it just truly exhaustion or like was there like a underlying heat, something more drastic that you just didn't discover? And if you didn't do a rectal temp at the time, you really can't know. And then, like I said, you don't rectal temp everybody. As if they're talking, you don't do it. But that's where like, your athletic trainer, they know the athletes better than the doc. So you just kind of see how they feel. Now with exercise heat stroke, that one should be like physician supervised and graded, and this should measure over in a couple of weeks. The NATA is also with collaboration with the Corey Stringer Institute. They tell you there's no exercise for about a week after you get discharged from the hospital, right? Depending on how many days you're in the hospital, whether if it was for like rhabdo, waiting for your CK levels to go down, or you're getting into some like coagulopathy issues, or like myoglobin, whatever it may be, a week after you get discharged. And then you have to confirm that all your labs are normal. Like, did your creatinine go down? Or your LFTs, normalized? So this is where you have to be primary care physician and get like routine blood work. But the progressive return should be over like 2+ weeks. You feel like once their labs have normalized, then you can start them with like a light exercise in a cool environment. And then you slowly kind of add intensity, add equipment, maybe add something sports specific to where eventually they do full participation. But they should only advance as long as they're asymptomatic. It could take like maybe 2 to 4 weeks before they can get back.
Yeah, and most of the time you're going to feel like crap so much, you're probably not going to be rushing that anyways. Or you would think,
Right,
hopefully.
right.
All right, I've got a couple myth versus fact for you. So myth versus fact. If you're fit, you can't get heat stroke.
False, right? So sometimes the more motivated athlete or the most athletic athlete, they'll override their own warning signals. So high level fitness kind of raises the capacity and concern. So yeah, false.
Okay, myth versus fact. Hydration alone prevents heat illness.
I would say false, right? So you have to think about like heat acclimatization and also load. And hydration is important, but that's not the only factor.
Yeah, I would say heat acclimatization is probably your biggest, right? If I was going to talk with an athlete or a team. All right, myth versus fact. Muscle cramps always mean dehydration.
False. Sometimes with when you're trying to condition, a lot of the cramping is actually from neuromuscular fatigue. If you ever try to start lifting heavy weights and your leg starts to shake, so sometimes these things are just more of like a neuromuscular loading issue. So, cramping does not equal dehydration.
Okay, myth versus fact. Heat stroke only happens on very hot days.
No, it could be a muggy 80-degree day and it just feels like you're working out through a sauna. So, yeah.
Sounds like November in Texas, right? In Houston.
Yeah, yeah. Yeah, like I said, I did residency and fellowship in Lubbock and that West Texas heat, that 90, sometimes that feels nice, man. And then one time I would come back to Houston, like I fly back from Lubbock and it's like 80 degrees and it's humid. I was like, oh, this temperature is so like it feels like it's so heavy. So false.
You know Tim Ratliff. We've hung out
Yeah,
with him before. He always says he's
yeah,
from Phoenix. He always says it's a dry heat. He says that about anytime we
yeah.
talk about Phoenix. And yeah, totally different than, wet heat or humidity, right? I've got a couple other ones, but you've already kind of answered them with your, great explanations. One more. Myth versus fact. If an athlete is sweating, they don't have heat stroke.
No, the false, because that's actually the telltale sign, like heat stroke, it's you stop sweating. And if you're heat and you're looking to have some sort of like CNS dysfunction or altered mental status, they stop sweating. And then that's why I get real concerned. And then you go dunk them. So I think that's the difference between like heat exhaustion and heat stroke. In heat stroke, you don't sweat.
Yeah. Last one. Myth versus fact. Once symptoms improve, the athlete can return to play that day.
Yeah, no. Especially after a heat stroke, man. Like I mentioned before, like there's gonna be some weird blood work labs going in. We gotta make sure that you're not having some end organ damage.
Yeah. Yeah. We've hit on that pretty well rounded. And I think that's one of the extreme cases that you're not going to see all the time. But when you do, right, it'll be, hopefully, if you're listening, you'll remember some of the stuff that we talked about.
And that's really important for us like primary care sports guys or any primary care doctors out there who's listening, who's having these as a follow-up. Be the good internist, be the good pediatrician and family doc, and like, monitor these labs after they get discharged.
Yeah. Where do you see the future going? A lot has happened. I'm thinking about this episode, and as I'm thinking, I grew up in the Houston area, played sports. You grew up in the Houston area as well, played sports, but none of this stuff was around, and that wasn't that long ago. It was 20 years ago. And, I remember we would practice during the summer. We would do 2 days. You'd, work out from 8 a.m. until 9:30, and then you'd have a break and you'd come back at 1, essentially after the coaches had lunch, and you would go from 1 to 3 and you do your camp. And then when pads started, we would do the same thing. And then during Thanksgiving break, we would do the same thing, Christmas break when we were, in the playoffs. So a lot has happened. Clearly, there's the Corey Stringer Institute. There's other. NATA has their recommendations. NCAA has theirs. UIL in Texas has their recommendations. The AAA in Arkansas. Where do you see the future of this going?
In terms of the future, I think awareness and now regulations are very big, especially in Texas. Now there's now like a mandatory like cold tubs, in case for heat and then monitoring. It used to be a recommendation, but now this year it's required. So awareness is going to be key. Depending on what kind of level of athlete you are, this is where, and you probably noticed in collegiate, that's why teams have bubbles now, like indoor training facilities. Now, I know high schools don't have, I'm sure there's some high school in Texas that may have some sort of weird indoor training facility, but scheduling is still the same facility. Where this is going to be like a little bit more of a hot topic, but like you may see the shifting of the season may change too, right? Are we not necessarily shorting seasons, but you'll see things adjust maybe like where football may start later or earlier, depending on how things are, especially in Texas, depending on heat on the wet bulb glow temperature, kickoffs may be delayed instead from 7 to even 7:30 or 8, depending on how hot it is. And I remember, Larry, you remember playing on those, sometimes at high school, there's like a 2 p.m. Saturday kickoff. And a lot of schools are trying to stay away from those like afternoon, especially in August and September, of those Saturday afternoon games. You're seeing a lot more Thursday night high school football games because of, one, there's more high schools now and just for logistical stadiums, but two, you really want to do like a Thursday, Friday, Saturday night football game, and we're trying to stay away from afternoon football games, or at least for high school.
Yeah. I mean, Rice's games are at 6 p.m. We rarely play in Texas or in Houston before 6 p.m. as far as games.
Right. And that's what we, in high school. Now, college is different too, because you have to add like TV times and stuff. But like I said, at the NCAA level, you have a lot more resources, and, they have like the cooling oscillating fans right on the bench for those 12 or 2 o'clock kickoff times. One thing I could probably see in terms of like a future direction is probably like hopefully improvement in like technology in terms of like wearables, not even like with sports. And now you're seeing people with like neck fans, there. So there may be some of like technology where like, besides like that little AC cooling oscillator on the bench, there may be some other things that you can do to keep the wind and conduction and convection heat when you're on the bench, during practice.
That will be down the road, and I feel like there's a market for that, particularly where we are in Houston. Cool. What are your big takeaways from today? If you want, coaches, athletic trainers, physicians, surgeons, all these people that are working around sports, what is your big takeaway?
For my fellow physicians, I would say that like heat stroke is, bottom line, a CNS dysfunction plus a core temp. So if you do sideline stuff like us, you treat that on site before transport. Okay. For our athletic trainers listening, we talked about it before about the rectal thermometer. You're already the person most likely to save this athlete because you're the ones who know who this person is and have a relationship with them, and they probably see you the most. The guidelines are on the AT side for this. For our fellow coaches, let the medical staff take care of what they need to do. Conditioning is never a punishment in the heat. So allow water breaks, allow cooling things. If someone's not feeling right, you take care. Let the medical staff and athletic training staff take care of them. In terms of like for everyone, most of the injuries doesn't necessarily happen in the games. It happens in practice, right? So make sure that practice guidelines should be universal, right? Get that wet bulb globe temperature and modify practice based on that temperature alone, and have a good EAP in case something bad happens. Make sure you know where your cold tub is. Also know where your AED is, Make sure that the stadium ops or practice facilities ops are just a phone call or a walkie-talkie away if something's bad, so they know when to activate EMS. So make sure that you know your EAP front and back.
Cool. anything that we didn't hit on as far as heat illness, wet bulb globe temperature, or anything related to the spectrum of injuries that we talked about.
Yeah, and this is not just for any athletes, for anyone who wants to be active outdoors. I would say if you're already thirsty, you're already behind, man. So like just keep up with your hydration. But if you're going to be exercising out in the heat, you got to acclimatize it to it first. So ease into it.
Cool. Thank you, Dr. Sulapas, and thank you for everyone listening today. I feel like the time of year, a very relevant episode. And then with the World Cup going on right now, also very real life, right? We talked about a lot of experiences, and you have a lot of experience with MLS. If today is your first time listening, download the BackTable app. You can find us on the Bone Sports series. If you're liking what you're hearing, like, share, tag, build playlist, leave a comment. You can also email me at larry@backtable.com. And with anything else you want to hear, anything that you think is cool. My name is Larry Balle. I'm a primary care sports medicine physician in the Texas Medical Center. And today we had Dr. Sulapas, Dr. Irvin Sulapas, who's also a sports medicine physician with us here in the Med Center in Texas and Houston with a ton of experience with heat illness. So I really appreciate you being here. Dr. Sulapas, do you have any socials that you would like to share that people can find you on?
You can follow me on Instagram. Mostly it's just pictures of me doing sideline stuff or just world travel. So you can follow me at Irvin MD. So IRVIN MD. If you guys want some travel hacks, you can hit me up too. I can help you guys with that. And then from Twitter, it's Sulapas. Those are my two main handles for social media. Feel free to follow me, or if you have any questions about sports medicine in general, or for any residents there who are interested in sports medicine, you can reach out to me or Larry.
Yeah, awesome. You can find me, Larry Balle, MD, on Instagram, or you can find me on LinkedIn, Larry Balle, Balle. Thank you again, Dr. Sulapas. Awesome. Thank you for joining us.
Yeah, thank you for having me.
Thank you so much for joining us on BackTable Bone Sport. If you haven't already, be sure to follow and subscribe. Rate the show 5 stars and share with a friend. If you have any questions or comments, direct message us at _BackTableMSK. That's _BackTableMSK on Instagram, X, Blue Sky, YouTube, and LinkedIn. BackTable is produced and hosted by myself, Larry Balle.
Our production team is led by Kieran Gannon,
Aaron Bowles,
John Reyes,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Caputo.
Administrative support provided by Judy Dela Cruz.
Thanks again. See you next time.